Now it's time to call the next speaker, Dr. Yahya Alzahrani. He's going to talk about a very important subject in the term of scalp buckling. Does it has a role in giant retinal tear detachment or no?
Assalamu alaikum. I would like to thank the organizers for the invitations. So no financial interest to disclose. As you know, the giant retinal tear was one of the most difficult disease or pathology to control till the invention of the Stanley Chang of the perfluorocarbon. Makes our life easy. And the success rate was increased from 58% to 94% after invention of perfluorocarbon. So conventionally, these patients need pars plana vitrectomy, and all of us agree on this. Do we need a buckle in these cases or not? This is the question that we need to answer. So I will share with you this case. She's a 9-year-old girl. She presents sudden loss of vision, her right eye, light perception vision, non-recordable pressure, very soft eye. This is how she looked clinically in the right eye. The left eye is completely normal. And this is the OCT, how it looks. And this is her ultrasound. You can see hypotenuse eye with the retinal detachments. So I decided to go on for vitrectomy, as we conventionally know that the vitrectomy alone is enough in these cases. Sorry, can you go back? As you can see, it's 360 giant retinal tear, all the retina folded over each others. We did vitrectomy and tried to remove the subretinal fibrosis or membranes and BVRs. Anyhow, it was like, it's not fancy surgery. That we did like a regular vitrectomy. We fixed the retina. Try to move on. You can see we open the ball now, and then we inject perfluorocarbon, and then as a normal vitrectomy in these cases, laser, and then air fluid exchange, then silicone oil. So this is the point here. Shall we go for air fluid exchange or silicone fluid exchange? I usually do air fluid exchange with very meticulous drying of the edge. However, it's 360. I never do the silicone fluid exchange. I always go for air fluid exchange. Anyhow, it was like a straightforward surgery. Next day, she was like this. I'm sure everybody of us here is happy with the results. And I was happy also. But in 2 weeks' time, she presented this picture. So I decided to take her again for vitrectomy. And the first surgery, we did everything. We did buckle, we did vitrectomy, we did the laser, we did oil. Everything is done. So I said, okay, what we have to add here in this case? So I add a buckle in this case. Yeah, let's move on. It was quite difficult with a lot of BVRs, subretinally and preretinally. I dissected the necrotic tissue, then I put the retina back, and then we support it with a buckle. You can see here, I use always in the recurrence, I use triamcinolone, always. And then I use also membrane blue to stain if there is any residual membrane, or try to peel ILM in these cases. Anyhow, you see the subretinal bands here. I remove it, and then we put the retina back. Okay, just move on, and then try to fix the retina. You see the retinal. There is a retinal fold around the disc, and try to organize the retina. Where is the macula? To try to find out where is the macula, and then we did laser. Then tighten the band a bit, and then oil. So this is how she looks second post-op day. So perfectly flat. But is the buckle adding any idea or value in this patient? Dr. Mohammed said no. But let's see if she's going to get a recurrence in 2 weeks' time. So this is how she looks 6 weeks later. She's still flat. And this is how she looked 3 months later. She's still flat. Yeah, but she developed epiretinal membranes. So I decided to go in and remove membrane under oil. I kept the oil there. I removed the membrane. I kept then the retina. This is how she looked post-operatively. Can you give us 1 minute more, please? And this is how she looked 6 months later. And this patient now 7 years out, and she's still flat. So is the buckle adding a value for the vitrectomy? In my view, yes. And this is especially in children cases, and especially we have PVRs and if the giant retinal tear 180 or less. And I will draw your attention to this paper, which is a multi-center study. It's a very interesting paper. I would urge every one of you to have a look on this paper. And they look specifically at these cases, and they look at vitrectomy versus combined surgery vitrectomy buckles, and they found the results in the vitrectomy and buckle almost similar. However, the combined is the success rate a bit higher anatomically, but it didn't reach the statistically significant point. But in the children, when they subdivided, in the children, it was statistically significant. You can see here is around, I'm not sure if we have like a pointer here. You can see the anatomical success rate is 88% compared to 56%. This is in children less than 18 years. So in my view, children, they have, could you open please the slides? So in children, you have to do it, in my view. And this is their conclusion. In the children, you have to do the success rate is much superior than the adults. And this is my take-home messages. Children, chronic detachment, presence of BVR, giant retinal tear, buccal vitrectomy. Thank you.
Thank you, Dr. Yahya. Maybe we can open again the floor for discussion and comment from the panelists. Dr. Osama.
Actually, we don't have strong evidence that combined vitrectomy associated with scleral buckle versus vitrectomy alone in joint retinal breaks will add. There is no strong evidence, but if we have more than 270 or 360 retinal detachment, I don't think it adds any rule. In my real practice, I add the scleral buckle in all joint retinal breaks except in superior retinal breaks. Or if you have a joint retinal break more than 270 or 360, like this case, the buckle will not add any benefits for this patient, in my belief.
Any other comments?
So just to comment here, I think the idea of buckle here is to relieve the vitreous space contractions. This is the main idea of the buckle in these cases.
Yes.
Yeah, good surgery with the difficult case, sure. If I want to add something, I think the furnace, it's for the first surgery, you done beautiful surgery with the beautiful dissection. I think that's it's better to use silicone oil in the first
It has been used.
surgery.
It has been used.
That's that's the first thing. Okay. The second thing, for me, when you have retinal electronectomy 360 degrees, it is any place for external annotation. Why? Because you don't the aim is to relax peripheral basic peripheral of the eye, and here you don't have any vitreous in the retina. You understand? And of course, with your laser, with your good temperament, all it's okay. But the PVR, if these cases relative to the myopia and relative to the PVR initially, take worse the result in final results.
Anyhow, my experience from this case retrospectively, I wish I did a buckle in the first surgery.
Just a last comment, Doctor. I appreciate the idea of the buckle is to reduce the traction if it happens circumferentially, but the idea of the buckle with the giant retina tear increases the slippage, incidence of slippage of the retina over the buckle. So maybe we have to consider this as well.
Yes, agree. So the buckle, it should not be high buckle. It should be, we call it lower lying buckle in these cases. Otherwise, we'll get slippage.
So, Dr. Yahya, wonderful surgery. However, I always combine scale buckle and vitrectomy in joint retina breaks.
Perfect.
However, in this case specifically, I will not combine scale buckle. The retina was cut 360 degree. The problem in this case is not the scale buckle. The problem is how to detach the posterior hyaloid in a young patient, 9 years old, with a detached retina. So this is the problem, and this is the cause of recurrent retinal detachment with PVR.
It's a very good point.
And also, we don't undermine the hypotony risk also. If you are talking about giant retinal tear, which has the hypotony risk, this is also another risk, which is the anterior segmental ischemia and so on. So, however, I know it's always a point of debate.
A lot of controversy
in
this issue, I know.
Thank you, Dr. Yahya. Thank you very much.